This is always a tricky question to answer. So I usually say to people, do you want me to lie or do you want me to tell you the truth?
If someone says to you, you've got a patient sitting in front of you, it's a mother and say their young child, and they say, what causes it? Why me? What do we do to deserve this? What do you say?
I honestly just say,
can we touch on some of those potential factors that may trigger type 1 to occur?
Yep.
But there are a lot of theories. What are the ones that are at least the most supported by evidence?
it's really a combination of genetics and an environmental trigger. And that environmental trigger is usually a virus. Yes, numbers have increased since COVID. We know COVID is a virus that has caused a significant increase in type 1 onsets.
Has the evidence actually shown that numbers of type 1 have increased since COVID? Let's say somebody does try a low-carb diet and they do have some really great success. I will admit, this was me when I was on my low-carb journey.
Did you get off insulin altogether?
No.
This is people's biggest aim, is we can get off insulin, and they have to understand that with type 1 diabetes, that is not going to happen.
Do you feel like you have to find a way to give advice without the judgment so that the person with diabetes doesn't feel shame and guilt around their numbers? How do you
I'm
juggle
really
that?
pleased you've asked that.
Let's talk about the link between diabetes and depression and anxiety. There is a strong correlation.
It's frightening.
And it's bi-directional.
I'm really glad you've mentioned eating disorders because I want to talk about it. Girls with type 1 diabetes are twice as likely to have disordered eating to those without. Now that's a massive statistic.
Yeah. You're carrying this load for so long. And as you say, diabetes takes no days off. And if you take even one day off,
You're punished for it.
yeah. So how do you say that to a kid
Yep.
who doesn't care?
They
just
don't
want to go back to school, eat lunch with their friends,
Yep.
play in the playground. How do you get that message across to a young kid?
Drew, if I knew the answer to that, I would retire happily. Don't let diabetes define you. Don't let diabetes control you. Try and make it the other way around. And don't let it stop you doing anything you want to do. Something I really believe, Drew, and I wouldn't have been able to have that conversation many years ago with people because there wasn't this exciting future. And now I really believe that it's changing fast. Having focused on, a lot of the doom and gloom, I'm hoping that my letter reflects a bit of that, but with a bit of a turn at the end. So hopefully I can get through this without crying. Dear diabetes.
My guest today is Lucy Casson, a paediatric nurse practitioner who has been working in the field of diabetes education for almost 25 years. Lucy is a wealth of knowledge. She's seen it all when it comes to diabetes management. This episode got off to a shaky start, pun intended, as I was having a low blood glucose event before we hit record. After a few jelly beans and some patience, my levels were back into range and they stayed flat at around 5.5 millimoles for the whole episode. Initially, I had a list of practical advice that I wanted to cover with Lucy in this episode, but the conversation took a turn and we ended up mostly talking about the mental, physical, and psychological struggles that people living with diabetes often face. We spoke about depression, eating disorders, and burnout. We discussed some of the stigmas, myths, and misconceptions surrounding diabetes. We talk about the language we use when speaking about people living with diabetes and why it matters. We debate whether time in range or time in tight range should be considered the new gold standard of diabetes management. We talk about the link between COVID infection and type 1 diabetes incidence, and so much more. And as always, Lucy closes the show by reading out her letter to diabetes. It was eye-opening for me to hear about diabetes from the perspective of someone who isn't living with it herself, but is very close to it due to all of the amazing work that she's done with her patients over her career, and continues to do to this day. This podcast wouldn't be possible without the support of Medtronic. I'm incredibly grateful, not just for their technology, but for the people behind it. Medtronic puts patients first. They truly care, and I feel it. So to my Medtronic family, thank you. Without further delay, here is your daily dose of Lucy Casson. I love how it's like phones on silent. When you have diabetes, it's like these alarms are going off no matter what. So yeah, this is, I was just saying to you before, like being at 3.1 millimoles right now, obviously feels terrible, but this is part of diabetes.
Yeah.
Like sometimes it's going to happen on a stage where it's a really important moment and you have to find a way to manage it. So I'm going to wait till I get up to the 4s and then this conversation will begin. Also, I've got new jelly beans.
Okay.
I hate eating jelly beans because they get stuck in my teeth and I feel like I need to brush my teeth and all the issues with dental health, which is maybe something we can talk about.
Yep.
Maybe there's some like other hypo treatments that are better. But I've got these new jelly beans and I don't even know how many grams of glucose are in a jelly bean.
There's nothing on the back of the pack.
I'm just guessing.
What made you change?
It's just convenience, whatever was there. What do you recommend for hypo treatments generally?
It really depends on the age of the person and how long it's been going for. So I guess usually start with around about 5 to 8 grams. And as we've over-treated hypos for years, which you'll probably know as well. So we try and get people to say, look, just have a couple and wait. But having sat here and watched you for the last half an hour,
Right.
I realise as a healthcare professional that's really easy to say, but I'm not sitting here feeling like you are and go, oh, just wait it out.
Still.
Yeah, you haven't moved.
Yeah, I mean, that's such a good point. And also, it depends on the context. This is what I try to tell people. Tell me if you agree with this. Not all lows are the same. Like,
No.
it depends on the context of the low.
Yep.
How much insulin do you have on board that's active? When did you last exercise? There's so many factors. So it's
How
not
many lows you've had in the last preceding 24 hours. Yeah.
right. So it's not as simple as this like perfect mathematical equation where it's like, okay, 5 to 8 grams, it's going to raise you by X amount millimoles. Like, it's tricky. There's all these other factors.
I think it's a starting point as a guide, but I was talking to a mum and her daughter the other day, and I said, what do you fight about most with diabetes? And the daughter said, she always tells me off for over-treating hypos. And she said she just doesn't get it. So this kid goes to the fridge and just keeps on going, and the mum's going, stop, wait, exactly as we tell you to. She said, you don't know how bad this feels, and you have to keep going till you feel better.
Yes, and you're in a panic mode.
Yeah.
You're literally in this fight or flight situation.
Yep.
Where you feel like you have to treat the low immediately.
Yep.
And get your blood, and it's the feelings are delayed. So even when my blood glucose will come back to normal, let's see where it's at now. I still
Do you have
feel
a fear
low.
of it going back up now? Because I know you've sat here and said, I don't want to have too much because it's going to go up too high.
Yeah, I'm now worried about having this rebound high
Yeah.
and then thinking, okay, I'm doing a podcast. What's my blood glucose? Is it above 10? Is my brain going to work properly?
Yeah.
Like, it's just a storm of thoughts and variables.
Which feels worse?
Definitely the lows.
Okay.
I think I can function quite well
Yeah.
in a higher state. Lows, I'm absolutely useless. Like, absolutely. Well, I'm 3.9
You're doing
now.
all right.
So 3.9 for me, I'm comfortable enough to like really forget about this for a minute and actually get into the conversation. But yeah, until I see it in this sort of 3.94 or above territory, it's like, ugh, feels a bit iffy. And I imagine some kids would kind of, in a way, love treating lows because they get to eat candy and jelly beans and snakes.
Yep, exactly. And many of them say that to me. But then a lot of them don't feel it. So the parents or teachers will just keep treating until they see that number come up. And you know yourself with the lag time, then they could be up at 15 now within half an hour.
Right, exactly. I remember my first ever low. I laugh about it now, but it's not funny at all. So I got diagnosed when I was 21. And I was told like what lows are and hypos and what they feel like and what to expect, how to treat them. All of that training went out the window when I had my first low because I was in panic mode. So I remember feeling, I wasn't wearing a CGM at the time. I remember like feeling a little funny and I was like lightheaded, but I actually think it was psychosomatic. I think I convinced myself that I felt low.
Yeah.
So I said to my parents, I was at home, we were about to have dinner and I'm like, I think I'm low. What do I do? And my dad's like, just check, do a finger prick, have a look. And my mom's like, no time to check, treat it immediately. And I didn't know what to do, so I just ran to the fridge and I just picked a bottle of milk and just drank half a liter of milk. I'm like, what am I even doing?
Yeah.
Like, it was pure panic mode. No one ever told me to drink milk.
Yeah.
That wasn't the way to treat it.
Have something.
Just have something.
Yeah.
Yeah, so I learned a lot. That was my first of many big diabetes-related errors that I've made, but you've got to make them, right? Especially early. I think fail early is a good way to do it because you learn early on. Well, now that I'm feeling like half a human again with a blood glucose of 3.9 and on its way up,
good.
Let's set the scene for people.
Cool.
So your background is as a paediatric nurse practitioner.
Yes.
And you've worked in the diabetes field for...
I'm trying to work it out. I would guess 23 to 24 years.
Right. So you're a true veteran. You've seen it all. What got you into the diabetes field? Like, how did that even happen?
This is always a tricky question to answer, but I'm going to be very honest with you. So I usually say to people, do you want me to lie or do you want me to tell you the truth? So I was a paediatric nurse in the UK and I was working with a community children's nursing team. So essentially we had sick kids at home. So in the UK, it's a very big model of care to keep kids out of hospital. So we had kids on ventilators, we had kids on dialysis, all at home. And we all each had our specialty in the team. And I was actually looking after the prem babies who, once they were ready to go home on oxygen, I'd look after them at home. But we also sort of all dipped into the 24-hour on-call stuff. And there was one particular year that most of my work, unfortunately, involved terminal care of kids with cancer and cystic fibrosis. And as much as that was an incredible job to do, it has a time frame on it. As you can imagine, I was in my 20s. I burnt out, essentially. And I said to my boss, I need to do something else for a bit. And she said, well, diabetes is getting really busy. Do you want to help me?
Busy.
My words were, I would rather stick pins in my eyes. And I look back at that now and I'm so ashamed because I just thought diabetes was boring. It was vanilla. I wasn't really interested. So I went off to Birmingham Children's Hospital in the UK. I did my diabetes course and really have never looked back. I found that as much as I lost a lot of my clinical skills as a nurse, I loved the education side of things. And as I said, it just led on to bigger and better things.
That's so interesting because you're so right about diabetes on the surface seeming like this kind of bland, boring condition that, there's all these different stigmas.
Yep.
But until you're either living with it, working with people who are living with it, or know anyone living with it, you realize that it's one of the most complex conditions.
Absolutely, yeah.
That requires arguably, and I don't know if this is true, but arguably the most day-to-day self-management of any condition that anyone has.
I would agree, yeah.
I mean,
I
we're
really
biased
would.
because we're in the field, but...
Yeah, but I've seen a lot in my career, and I would agree. It's a really good point, which I, as a nurse, had no idea. Right,
and I remember when I was learning about diabetes at university, I was doing my undergrad in sports science. I remember learning about, if an athlete or somebody that you're working with has diabetes, you prick their finger. It seemed so easy. It's like, you prick their finger before enough. Simple. Yeah, I can do that. And then I got diagnosed with it, and you realize that, I'm still learning and still making mistakes. Like it is just this endless pursuit.
Yeah.
So why don't we define some of the terms when it comes to diabetes? Because again, like diabetes is an umbrella term for so many different types.
I know.
And I feel like over the years, even more are coming up. There's 1.5 and 1 and 2 and LADA, MODY, gestation. There's so many.
Yeah.
How would you define diabetes as sort of like if we zoom out and think big picture and then we'll zoom in on a couple?
So as a general term, and there's many people with type 1 and type 2, not to mention the others, will say they need to be given different names. But I would just look at diabetes essentially as a lack of insulin in some way, shape or form, right? So, and I guess the difference, I'm going to start with type 1 because it's what I work with predominantly. And type 1, what we know about it is it's an autoimmune condition. The way I define it is there is zero insulin production. So the body has destroyed the ability to produce insulin. Mm-hmm. That's type 1. Type 2, there is still insulin production, but for various reasons, whether it be lifestyle or genetics, the body can't use that insulin properly. So that person will need a little bit of help. You've then got your gestational diabetes, which is defined as diabetes diagnosed in pregnancy. So what people know that causes this, again, there's a slight lack of insulin production, or the hormones produced by the placenta causes an insulin resistance in the mum. So she has to, again, have additional help, be that lifestyle changes, be that insulin or be that medication in tablet form. And then it starts getting a little bit more complex with your LADA and your MODY that you mentioned before. So your LADA is a latent, I always get this wrong, autoimmune diabetes of adulthood. And it's often misdiagnosed as a type 2 just because of the way people present. It's often called type 1.5. And what we know about it is that it often presents in either late adolescence or early adulthood. Mm-hmm. And it can take a lot longer. Well, it does take a lot longer than type 1 for the person to require insulin. Right. But essentially, they usually will.
So that honeymoon phase, so to speak, is a bit
is prolonged. A long one. Right. Yeah, absolutely. And you can go for, a good period of time without insulin. And then getting really complex are your MODYs. So this is mature onset diabetes of the young or of youth. And again, this is often misdiagnosed as a type 1. But what we know about MODY is it's caused by genetic mutations. There are lots of different types of MODY, and this is what people don't realize either. I'm going to say I think there's about 15 different types. Yeah. And depending on which genetic mutation exists, depends on the treatment. Yeah. So some people with MODY will be diagnosed as a type 1, and then they're not really behaving like a type 1. So further testing will be done. You'll find out they're a MODY. Some of them can come off insulin altogether, which is great for those people. Right. Some of them will go on to oral medication, And some of them, again, will have lifestyle changes, but it all depends on which strain of the MODY you have as to what treatment is required.
Yeah, diabetes is so complicated. So let's sort of zoom out for a sec. So diabetes is an umbrella term that basically describes hypoglycemia or high blood glucose due to either lack of insulin production or ineffectiveness of insulin action.
Exactly right.
It can be caused by genes. In many cases, even type 1, there's genetic predispositions.
Yep.
Type 2 even, I think people
Yep.
don't realize that
Absolutely.
you can have certain genes that predispose you
Yes.
to getting type 2.
Yep.
LADA, MODY, we've spoken about all of those. So there's a genetic thread
Yep.
that runs through all of them.
There is, but that genetic thread, again, is complex. So a lot of people with type 1 will say, or a lot of parents of the kids I look after will say, should we get the sibling tested? So you can test positive for the genes or the antibodies to potentially develop diabetes, but that doesn't mean it's going to happen.
Right.
So what I often say to people is actually, unless there's a clinical trial happening that's trialing certain drugs or things to prevent the onset of the disease, don't bother doing it, because you might look at somebody, yes, they've got the antibodies to potentially develop diabetes, but it might not happen. And I think, I don't know, your parents may say different, but as a parent, you're watching and you're fearful of something that actually might never be an issue.
Right.
And if it does become an issue, we actually don't know how to stop it happening.
Exactly.
So I think it's a bit of a curse in disguise to get the testing done.
Yeah, I would agree with you with that. I think it'll come down to the personal preferences of an individual and psychologically how they tackle with it.
Yeah.
But if I told you that there were 6 other conditions that you're genetically predisposed to, would you want to know? No. It's like I personally wouldn't, but
Yeah.
I think some people would. There's also a lot of cases where people are misdiagnosed as one form versus the other. A really good friend of mine recently got diagnosed with what seemed to be type 1 in the beginning, immediately went on insulin. Long story short, they figured out it was MODY, went off insulin, started taking an oral medication, controlled beautifully.
Yeah.
Is there like a framework or a way to sort of like flow chart our way down? Okay, so you get a high blood glucose reading or you're on your way to hospital with ketoacidosis, whatever it is. How do we figure out what type of diabetes somebody has?
Look, I'll be honest, I think it very much depends on area where you are and who your treating healthcare team is. There's obviously, like anywhere, some places are better than others. Some people are more knowledgeable than others. What I'm still seeing, sadly, are many kids being missed. So if the parent will take them to the GP for often months on end saying there's something wrong with my child. And you'd know yourself, just a quick urine test or a quick blood test will diagnose diabetes, but it's unfortunately often just put down to it's just a virus, take them home, they'll be fine. So these kids are coming into hospital incredibly sick in ketoacidosis, requiring intensive care. But then, like you say, you've got the other side of things where it's what type of diabetes is it? And quite often things will look like type 1. So they're diagnosed as type 1, or they will look like type 2 without that further testing happening. Now, the MODY testing is expensive. So it's not something that's automatically done. But like you say, there should be better guidelines in terms of if somebody's presenting like this, but they don't have this and they do have that, this is what we should be doing.
Right. I mean, it is very tricky and it can take, as you say, a lot of time to really dive in and do all the tests. So I understand why doctors want to just act quick and sort of have a stab at it. But yeah, there needs to be better guidelines around that. What about type 1? Because I remember when I was diagnosed, the first question I asked the educator was, what causes it?
I knew you were going to say that.
And this was 13 years ago now, and the answer was very underwhelming and it didn't sit well with me.
What was the answer?
We don't know what causes it. And at the time, that wasn't good enough for me.
Yeah.
But now, having lived with it for so long and doing so much research of my own and doing my postgrad in diabetes education and all that stuff, I realized that was the perfect answer.
Yeah.
We still don't
It's
really
still the
know.
answer. Yeah.
I mean, we have some ideas around certain triggers, maybe environmental or viral, but there is we know what causes it.
Nope.
So if someone says to you, you've got a patient sitting in front of you, it's a mother and say their young child, and they say, what causes it? Why me? What do we do to deserve this? What do you say?
I honestly just say this is really rotten luck. That's all it is, and it doesn't make it any easier to accept. But I just explained to them that there's nothing that they ate or didn't eat that caused it. There's nothing that mum did wrong in pregnancy that caused it. There's none of those lifestyle factors that people unfortunately will say the wrong thing that have caused this to happen. What I say to them is your immune system has unfortunately gone off on a little bit of a tangent and it's destroyed something that's working perfectly well. And in your case, it's the cells that make insulin, and there's nothing anyone could have done to stop it.
Can we touch on some of those potential factors that may trigger type 1 to occur?
Yep.
What are some of the main ones that come to mind with the best research? I mean,
Sure.
I've heard dozens of theories online by bloggers and people
Yeah, I'm
who,
sure.
don't really have credibility to speak in the space, but there are a lot of theories. What are the ones that are at least the most supported by evidence?
So look, it's really a combination of genetics and an environmental trigger.
Right.
And that environmental trigger is usually a virus. Now, the virus happens, the body's immune system comes out to fight the virus, and in that step, it then goes off and destroys something perfectly functioning. The person has to have those antibodies to have that response.
Mm-hmm.
Now, there are talks of what causes them, things like gut biome in babies, things like breastfeeding or not breastfeeding. There isn't a firm amount of evidence to say what has really increased that. We were having a conversation about COVID earlier. Really interesting conversation that, yes, numbers have increased since COVID. We know COVID is a virus. But is there something else in that virus that has caused a significant increase in type 1 onsets? Who knows?
So have the numbers gone up? Because I've heard like people talking, but it's more like sort of online chatter. Has the evidence actually shown that numbers of type 1 have increased since COVID?
Look, it has. And I had a little look at this because it's something that people ask me a lot. And I think just if you think about it, people said, well, yes, we have noticed there have been more cases. Mm-hmm. When I had a look at some of the international information, what they saw was quite significant in that diabetes in most countries was on the increase by about 5 to 6% per year. What they saw in the first year of COVID was about a 13 to 14% increase. Whoa. And in the second year, up to 26% increase. So I sort of delved a bit deeper because I thought, well, is it because it's a new virus that is triggering a stronger response? And then there were theories such as thinking about what the healthcare system looked like during the first year of COVID. Everybody was in lockdown.
Right.
So a lot of people's diagnoses were perhaps delayed,
right.
which then might indicate why there was such an increase in the second year because people were then starting to go back to their doctors. There were also theories around we all became really, really good at keeping germs at bay. Mm. So we were hand washing. Our hygiene was something that it's never been and probably never likely to be seen again. And again, we know that exposure to certain germs improves our immune systems.
Right.
So were these kids' immune systems significantly weaker because they weren't being exposed to germs and therefore had more disposition to have this response? Wow. There's not enough on it, but the stuff I've read was really quite interesting.
That's so interesting. So people are at home,
yep.
less exposure to other people and other, healthy sort of pathogens or bacteria, and there's the hygiene hypothesis, so like way over sanitizing everything. And, and then again, like as you say, how many of those people may have figured out they had diabetes, but it would have been spread over 12 to 24 months, but everyone is at home, at the same time.
Absolutely.
And then I heard, we don't have to touch on this because this is controversial. There's obviously people who are going to say, no, it's the vaccines that are causing an immune response that are causing people to develop type 1 diabetes. I don't know if there's any evidence. I have not looked into it at all. Have you seen anything about that?
I try and avoid it because I don't like getting into the conversations. But what I would say is first and second year of the COVID pandemic, we didn't have vaccines. And we saw an increase in presentations. Yeah. So I would discredit that theory, but I do understand that people do have a right to go down that hole. Right. And it's something that I'm not going to sign up to.
Yeah, no, fair enough. No, but it's one of those topics where at least there's a path of logic. Like so somebody like me, I'm living with diabetes. Or let's say take someone who maybe doesn't have any background in diabetes education or any scientific background. And they think, well, I've taken a vaccine that has triggered my immune system. What if something happens downstream? Yep. So I'm not saying these people shouldn't have these thoughts. It's fine. Yeah. But we need to have a way to actually figure out correlation, causation, and all of that sort of stuff.
Absolutely.
So when you think about type 1 diabetes and people getting diagnosed, you're working with kids, obviously, and maybe as young as babies. One of the sort of myths or misconceptions that I hear a lot is that people think you're born with it.
Yep.
Can you be born with type 1 diabetes, or is it always something that develops later on?
Yeah, it's a great question. It's one I'm asked a lot. No, you can't. You can be born with the genetics to potentially develop it, like we spoke about before. But there are cases, I mean, the youngest child I've looked after with diabetes, in inverted commas, was 7 days old, 7 or 10 days old. And there are forms of neonatal diabetes, which obviously neonates are in the first year of life, that will be diagnosed. And again, they're often misdiagnosed or called type 1 diabetes. They're not. And the thing with neonatal diabetes is, again, similar to those MODY presentations, there can be, or there often is, some form of genetic mutation that happens. Many of these babies who are diagnosed with neonatal diabetes, it's transient. They grow out of it. So they will be on insulin for a while and they will look and behave like a type 1, but they're not. Now, some of them will then turn into a type 1 having had neonatal diabetes, but no, you can't be born with it, essentially.
So on a like pathological level, what's happening to the pancreas of those neonates that have little to no insulin production, but then the pancreas sort of kicks into gear later on? Like, what is actually going on there?
It's usually, as I said, formed by some syndrome that has many other components to it, diabetes usually being the easiest to treat of these. So these are really complex medical conditions in these kids that the pancreas is just resting, or the insulin that it's producing in certain cases is being ignored by the rest of the body's hormones, etc., because of what's wrong with this child. So that's why it can become transient. Or those insulin producing cells will suddenly then go, this is what we're supposed to do.
Wow. I can only imagine how relieved the parents would be when the pancreas wakes up again and they know they're going to have a healthy kid. Do they have an increased risk of developing diabetes later, or is it sort of like once you're clear,
I actually don't know the answer to that. It's something I should.
Because in gestational, obviously the risk of type 2 increases quite a lot.
In both mother and baby, yes.
Right.
Yeah.
So if you are a mother with gestational diabetes, your odds of developing type 2 later in life is something like 30-something%.
Yeah.
It's quite a high percentage.
And I don't know what it is for the baby, but
Same,
babies born to gestational mothers have an increased risk of type 2.
And an increased risk of weight gain, is that right? Like a high BMI? Yeah, I mean, it's very, very complicated diabetes, and there's so many obviously different types that we just spoke about. But I think for today, let's really like hone in on type 1.
Yep.
So take me back to you become a nurse practitioner. You decide you want to go into the field of diabetes. Did you make a conscious decision to stay in pediatrics, or was it like, have you dealt with adults and older and the whole gambit?
Yeah, so the nurse practitioner thing actually came later. That came after the diabetes, so I'll tell you about that. Okay. But the pediatric side of things, so I'm UK trained, and when you train in the UK, I don't know if it's still the same, you select your specialty. So I'm limited to pediatrics only. I do see a couple of adults with the endocrinologist's permission, but it's a bit of a tricky minefield with restrictions on my license, essentially. So when I went into diabetes, as I said, it was really just to get a bit of a break from looking after the really sick kids. But then I decided I really liked it. And that led to a job opportunity here. So I actually called the Children's Hospital and said, I'm thinking about moving to Australia. Have you got any jobs? And they said, well, actually, our diabetes nurse handed in a notice today. So I came out, and the rest is kind of history. And then in 2000 and, I completed in 2009, so it must have been the 3 years prior, I decided to further my training and become a nurse practitioner. So that just involved me going through the University of Newcastle, and I did a master's in diabetes, which was a master's of nursing, but the nurse practitioner program. So that enabled me to be able to diagnose, be able to just function at a higher level, prescribe, all that sort of stuff.
Right, okay.
Which led me into private practice.
Got you, okay. Yeah, that's super interesting. So over the years, like if you take me back to when you first started working in diabetes, how has the diabetes healthcare landscape changed? Like what was the technology like when you
Hugely.
Take me through that.
So I did a few years in the UK before I moved here, and insulin pumps were not a thing in the UK. Now, whether that was mostly likely to funding, but we had one kid, and I still remember her name, on an insulin pump, and I was terrified to go anywhere near her. CGM didn't exist. So people were finger pricking only, giving injections, be it twice a day. We were mixing insulin, doing all that sort of stuff. Now, then when I came to Australia, I suddenly sort of started seeing all these people on insulin pumps, so I had to very quickly learn about them. Then CGM came about, then new insulins came about. And so it's just been unbelievable. But the last, if you told me 7 years ago that I'd be training people on how to use insulin pumps which self-adjust, I would have laughed you out of town. And now that's exactly what we're doing. It's it blows me away daily how quickly this technology is continuing to evolve.
Yeah. I feel like the iteration, like even a blood glucose meter is pretty amazing technology if you really think about it. But we're so spoilt now with tech that just seems so antiquated.
I know.
And like a CGM is incredible, but I'm sure the next iterations we're going to think, what? We used to wear this clunky CGM on the outside of our skin. We're probably going to have some, an implant or who knows what's next.
Well, the first CGM that I saw, so obviously you know all about finger pricking, but the first CGM I saw was a blinded CGM. So we would use it in the hospital just to see what Drew's doing for a week. Or I think it was 3 days at the time, and it would be a massive sensor, quite uncomfortable.
So blinded to the person wearing it. So
blinded and to us.
And to the
until afterwards. So it was sort of downloaded retrospectively and you'd see what was happening. So there was a wire, there was a device probably about half the size of your mobile phone, but thick, that you had to clip onto your belt and enter in glucose levels at various times of the day. There was a wire going to this big, thick old sensor which would sit under your skin. And then when you went, this is the best bit, when you had a shower, we used to have to give these shower bags that you'd hang around your neck to put this thing in.
Keeps dry.
It was CGMS Gold. We thought it was brilliant.
Wow.
And now looking back on it, I just go, wow, we've come so far that now when I hear people say, oh, my sensor's not communicating with my phone, I go, do a finger prick.
Yeah.
We've forgotten the basics, and in some ways that's great, but in some ways it's good to remind people that we've only had CGM for 7.5 years, really available financially to people.
Yeah, that's such a good point. We get so spoiled because we're so used to having it around us and working so well that if anything goes wrong, like sometimes I'll catch myself, I spoke about this on a previous episode, like my CGM alarm will go off in the night and I'll be like, oh, bloody CGM. I'm like, actually, that thing's keeping me alive.
I told you.
Yeah. Like that is the most beautiful sound because it's literally saving your life.
Yeah.
So yeah, pumps come on the scene. CGMs, now we've got these automated insulin delivery systems that are automatically adjusting. How do those work? Because I know that there's obviously people listening who use them, but there's a lot of people that probably have never even heard of this or don't know that it's available. So how do we explain to people what that automated system is?
Yeah, so you've got an insulin pump with rapid-acting insulin, which is continuously delivering the rapid-acting insulin under your skin. It then communicates to the continuous glucose monitor. So essentially every 5 minutes or every 10 minutes, the CGM is telling the pump, A, what the glucose level is, but what the predicted trend is in the next 30 minutes to 1 hour. And then what the pump does is it adjusts the insulin in response to that. So every 5 minutes, it's either increasing, decreasing, stopping, or keeping the same insulin. But then in addition to that, if the glucose level is slightly higher despite the increased background insulin, the pump will then give microdoses of corrective insulin as well to bring you down. So it's basically doing the work of a pancreas.
Right.
Currently, the person wearing that still needs to enter in their carbohydrates for food. However, the next generation is going to be doing that for them as well.
Right.
So,
and if people don't enter because I know people who don't, and they'll let it spike, the pump will still correct. They'll have a little bit less time in range and they'll have a little bit like larger spikes compared to if they were pre-programming and getting that bolus ahead of time.
Most of the time.
So
I've got, some people, and I cringe years ago when I think what we used to have criteria for people being allowed to, you had to earn a pump. And it's awful when I think about that now. You have to earn a pump.
What's the criteria to earn a pump?
You had to be well controlled. You had to do X amount of finger pricks a day. You had to be really good at carb counting. You had to... all sorts of compliance. Again, I hate that word.
Yeah.
And now people say to me, who's eligible for a pump? I would say whoever wants one.
Right.
So I've got those teenagers who we would have said that they just weren't well controlled enough, 7 years ago to get a pump. No, they can't get a pump. Now you put those kids on a pump and they're getting more insulin than they ever would have got because the pump is accounting for those meals that you said. So you could have somebody whose time in range was 23% on injections and you put them on a pump and they're still doing nothing. They're still just getting the insulin. They're not entering in their carbs and their time in range could easily go up to something like 60%. Now that has to be a better outcome for their health than the alternative. So I have got people who challenge it, and especially people who don't eat huge amounts of carbohydrates. These pumps are that clever that they can cover them, but still the advice we give is the gold standard is still to enter in those carbs and wait for the next generation.
Right. That sounds almost the opposite of what I would expect. You would expect that the people with the worst control would do the best on a pump.
Look, they do, and the research does say that, but the people who are already doing brilliantly will do even more brilliantly.
Okay.
But yes, certainly the best outcomes do come from
Especially if
those
they're
who are the
skipping
worst.
doses and they're a bit, lazy or young, and they're, young kids, they're not thinking like an adult would around like planning ahead and all those kinds of things.
Well, the potential of a 40% increase in time and range, I just don't see how you can ignore that.
So 40% increase time in range just by swapping from MDI to pump.
Yep.
That's what the research has
and doing
shown.
nothing with it, to still continue to, I guess, ignore that diabetes, but letting these algorithms
That's incredible.
fix that.
So how has clinical management changed? Go back 25 years. What was considered well-controlled diabetes, and like how is that different to today? Because I imagine today some people are having almost non-diabetic levels of like HbA1c and average glucose.
Yeah.
How have you seen it change over your career?
I think time and range is a big conversation because it's something really I myself have only started talking about in recent years.
Right.
And I think that's again due to these pumps and CGMs. So we always focused on HbA1c.
Yep.
It was always that golden number. You had to be this number to be allowed to drive. You had to be
Right.
this number to do certain things. Whereas what I would see, and you'd know this yourself, is an HbA1c is actually quite easy to manipulate.
Oh yeah.
So
Yeah.
right? It's an average. It's a snapshot. It doesn't equate. Five people with the same HbA1c can have very, very different time and range. So I think, first of all, it's that shift towards looking at how much of the time are you actually sitting in target rather than what your blood results are saying. And those insulins and those ways of delivering the insulin have got much better. And even if somebody doesn't want to pump, there's no reason you can't achieve very spectacular time in range on multiple daily injections.
Yeah, exactly. I mean, that's sort of the case that I'm in at the moment. Obviously, I went to see your colleague, Jane, and we were talking about, should I be thinking about going on a pump? And the only reason I had the temptation is because people were asking me. I didn't want to. I just still don't want to. I'm really happy on MDI.
Yeah.
And so she looked at my CGM and she said, the benefit, there will be a benefit, of course. But it's a cost benefit.
Yeah.
Like, what is the cost? What's the psychological cost, the learning of this new technology, financials, all those kinds of things? We decided that I actually probably don't need it. I was doing some research around smart pens and the improvements in clinical outcomes just by changing pens. So it's similar to what we were just saying, going from MDI to a pump, 40% increased time in range or whatever the metric is, like some sort of improvement that just comes with literally shifting from one technology to the next. The same actually is true for smart pens, which are amazing. I'm using Medtronic's InPen.
Yep.
So if you're on MDI and multiple daily injections, for those who aren't sure of the acronym, and you switch to a smart pen, you will see an improvement in A1C, most likely. Like, this is an average in the studies, but there is sort of benefit to even just, if you don't want to go all the way to the pump and you just want to sort of bridge the gap and still have that data, smart pens are a good option. Do you see many people using smart pens, or is that something that hasn't caught on yet?
Yeah, look, not in my population, and that's purely because all my kids are on CGM. Most of them are on pumps. So of those on injections, they're moving towards a pump. So it's smart pen is a really great stepping stone for that. But I think going back to what you said about the improved control by going to a smart pen, I think this is again where we have to really give CGM credit, because when you said how much the management's changed, people would come and see me in clinic, and you would probably remember this yourself, and you'd bring your book. You'd bring your book where you'd written down your numbers, but they could be 4 numbers a day. So you're looking at a snapshot of pre-breakfast, morning tea, lunch, dinner, for example, pre-breakfast, lunch, dinner, bed. You don't know what's happening in between times. No. And we would be basing our insulin adjustments on the assumption that if somebody's waking high, oh, well, then they must need more long-acting insulin, as opposed to, did they have a hypo in the night that we didn't know about? So CGM as a tool, I think, has been the foundation of changing everything for what we do.
Right. The CGM is plugging all of those holes in between those one-off finger pricks that in between those two finger pricks, you have no idea what's happened. Highs or lows, factors involved. And also, I remember I used to bring my logbook to my educator. I wouldn't write everything down.
Of course you wouldn't.
Sometimes you're ashamed of some of the things that you've done or haven't done. And I've used this analogy so many times, so I'm not going to use it again. But sometimes it feels like, as a patient, you come to see your educator or your doctor and you're being assessed or judged on your performance, your diabetes performance. What does it feel like as a practitioner? Do you feel like you have to find a way to give advice without the judgment so that the person with diabetes doesn't feel shame and guilt around their numbers? How do you
I'm
juggle
really
that?
pleased you've asked that. It's massive, and it's something I've definitely been guilty of in the past, because you're told this is what you have to achieve in an appointment. This is the things you have to cover. If somebody's not doing the right thing, you do X, Y, and Z. But fortunately, I learned very quickly that there's no point telling they already know what they're not doing right.
Mm-hmm.
They're already, I would see people sitting crying in the waiting room. I'd say, why are you crying? And they said, because I'm going to get in trouble. And I just think, as a healthcare professional, the fact that somebody has turned up to their appointment, pat them on the back for that. You know, they've turned up, they want help. Parents play a big part in this as well, because obviously they will point to us and say, well, you're going to get in a lot of trouble with Lucy if you're not doing the right thing. And it's something that I really discourage, because it's just, as I said, they've come to the appointment. The appointment should actually be about them, not what I want to do with them. There is a degree of that, but there also shouldn't be that fear of judgment, because, as I said, they know what they're not doing right. They're coming to you to ask for help at how can I get back on track. So I just think punishing people, judging them, using language even that says you're not doing the right thing, it doesn't work. It really doesn't work.
Let's talk about language, because that's an interesting one. The language we use in the diabetes world has changed over the years.
Yep.
A person living with diabetes, not a diabetic.
Yep.
What role does language play, and how important is it? Do you think there's times where a little bit too hyper-focused on language, and some people get offended by certain phrases or terms or stigmas? How important is language, and how do we use it appropriately?
I think that look, it's the world we live in nowadays. In all aspects of life, we have to be more careful about what we say and the language we use. But certainly when it comes, to health, I think, there are people out there who will say to me, I don't care if you call me diabetic, it doesn't bother me. But there are other people who find that deeply insulting. And I think my job is to establish what's comfortable, what's not, and try and use as harmless language as I can. And even down to before, when I used the word compliance, we don't use that word anymore in diabetes. We always used to, it's a non-compliant teenager. And now again, I cringe at that, because it's just not, it's judgy, and it's putting a label on somebody, and it's not appropriate. People will call me the diabetic nurse. Firstly, I don't have diabetes, but if I did, I don't think I'd like to be called diabetic. And people say, well, why? And I said, well, if you meet someone with cancer, would you call them the cancerous person?
Right.
And they just look at me in horror. I say, it's the same thing. So you've got to realize that for some people, that is a term that they really don't like. So a person with diabetes is becoming a lot wider term. Even calling glucose testing, some people don't like, because a test implies a pass or fail result. So they'll call it checking instead. So I think it's just being mindful of what connotations those words might have for certain people.
Yeah. I also think that if you don't have diabetes, if you don't know someone with diabetes, it's so easy to use language that you don't even know is offensive. And this is true for everything, right? You can offend people if you don't. It's almost like this ignorance where if you don't know enough about a topic, you can easily say the wrong thing and offend people. And I think it's the responsibility of the person living with diabetes. I nearly said the diabetic. The person living with diabetes, but I didn't. I got there.
Yeah.
It's almost your responsibility to understand that people don't know, and you can use it as an opportunity to educate.
Yep.
So I recently did a post on Instagram where I was talking about like the top 3 stigmas, or the top 3 things that people say to me when they find out I have diabetes. So it's like, number 1 is, but you don't look like you have diabetes. Another one is, did you eat too much sugar as a kid? What else? There's so many of these like one-liners that are just like these throwaway lines that people say, not knowing that it may offend people. Thankfully for me, I take zero offense because I understand the position they're coming from, but some people do get offended. What are some stigmas, myths, misconceptions that you hear a lot of?
A lot of that. So it mostly around parents. So when a child is diagnosed and that parent is already in an incredibly vulnerable, feeling guilty state, when they leave the hospital, they'll tell friends, and friends will say, oh, is it because you gave them the wrong things to eat? Or it's because, I always thought they ate a bit too much cake. Those sorts of things. Or the weight question, well, you don't look like you are. The other thing I find in schools, and I find this quite interesting, is young kids are often so self-absorbed they don't actually even notice that somebody else might be different to them. But as they sort of get older and they'll find out their friend's got diabetes, they might go home and tell their parent, and then they come back and say, my dad said you got diabetes because you ate too much cake. Or the other one is they worry about, will they catch it? So when I do school visits, the very young children that I talk to, and I say, has anybody got any questions? Without fail, the first one is, are they going to die? And the second one is, will I catch it?
Yeah, I guess the perspective of a young kid is they just think, am I next? Like,
yeah.
could I get this?
Yeah, I
like,
don't want to sit next to them.
Right. Wow, that's actually really sad.
Yeah.
I actually had that from a person in their 20s when I was diagnosed.
Yep.
I'm not going to say who it was because it's a good friend of mine. I don't want to embarrass him. But it was a guy that I was like literally one of my best friends. And he's like, this might be a stupid question, but is it contagious? And I said, that is a stupid question, but no, it is not. And, he was almost relieved.
Yeah.
But also, you kind of, they're finding a way to show, they're trying to show compassion. They're like, oh my God, this is quite serious. I've seen what you're going through.
Yeah.
I really hope I don't have to go through that.
Yeah. But surely you can fix it.
Yeah.
Surely you can take a pill.
Right.
And it will go away.
Well, that's another one, right?
Yeah.
So that's one of the other myths that I hear is,
well, parents will be told, don't worry, your child will grow out of it.
you grow out of it.
Yeah. Bathe in camel's milk, that will cure you.
Low carb diet.
Yeah.
Cures
Yes.
diabetes.
Yeah.
Just go low
Massive
carb.
one.
There's so many of those. I mean, there's like slap therapy and all these crazy things that people say.
Absolutely.
What are some of the craziest you've heard?
That I'm being paid by the insulin pump companies or the insulin companies to keep the cure a secret.
Yeah.
That's a big one, which makes me a bit wild.
I hear that a lot.
The slap therapy was a horrendous story, which I still can't even bring myself to talk about. But yeah, there's a lot of people, and obviously any parent is going to jump online and try and see what can I do to fix my child. And it's horrifying, some of the money that's being made.
I know.
In selling people this essence of goat wheat, all of this stuff that people are told.
Cinnamon.
I was just about to say the cinnamon, put cinnamon on everything, that will cure it. So it's look at the media is not faultless either, because they will talk about diabetes as diabetes. And quite often when they're talking about diabetes, they're talking about type 2, how to reverse diabetes. So people assume you can reverse it.
Right.
A lot of my own friends who have known me a long time say, oh, that's right, you look after the fat kids. And it's just, I just shake my head in dismay and say, have I taught you nothing?
I know. But that's one of the things about social media that is like a blessing and a burden at the same time, right? So you've got access to so much information.
Yeah.
So easily. You can go on any website, any social media page. You can look for answers, which is kind of amazing. Like, it's nice to know that you have the ability to find answers.
You don't know what's true and what's not.
So the problem with that is, for as much information there's probably 10 times more misinformation. Yeah. So how does somebody figure out what is good information and what is misinformation? Like, what do you say to people? Like, how do you tell people, no, don't listen to that person, listen to this person? Or, and we were talking about COVID earlier, but I feel like since COVID,
it's got worse.
Yeah, there's so much distrust in people of authority and medical professionals. It's almost like people like hate doctors and scientists now.
I think the best we can do is guide people to reputable sources. But like you say, again, if they've already got that distrust there, it's a really hard one. I guess gaining people's trust and confidence is huge at diagnosis when you're educating families. Now, we're in the very fortunate position that those families very quickly see what insulin has done for their child.
Right.
So they've had the weeks leading up to it where they've got a very sick, very thin, very unwell person in front of them, and literally within 48 hours, they say, I've got my kid back. Yep. I don't think you can deny the benefits of insulin there. So I think once you've got someone to trust that side of things, you can then, and I always say to people, there is a lot out there which is going to confuse you, it's going to contradict what we've said, and it's going to potentially lure you down a fairly dangerous, for want of a better word, path. You guide them to the well-known organisations, you're formerly known as JDRF, your T1D, all those educational resources and groups of people that they can be involved with. But inevitably somebody's going to go on social media and find something. And I could go on social media tomorrow and say diabetes is caused by driving too fast. Right. And nobody can say it's not true. Right. Yeah, so exactly. I think it's just about, it's gaining people's trust without doubt.
Yeah, it is tricky because it's also hard to completely discount people's positive anecdotes, because like, let's say somebody does try a low carb diet and they do have some really great success.
Yep.
The HbA1c goes down, time in range improves,
Yep.
they feel great, their body composition changes, they lose
Yeah.
body fat, gain some muscle.
Yeah.
They are going to then, and I was this guy, I'm putting my hands up, I will admit, this was me when I was on my low carb journey. I went to social media with this, I found the answer. This is the solution to treating diabetes. Just go low carb or keto, all of these benefits are going to happen, blah, blah. It's just so short-sighted. That doesn't take into account the fact that everybody's a little bit different.
Yeah.
Some people will benefit from that. Some people will do terribly on it. Some people will have both accounts. Some people will do really well in the beginning and then terrible later on, which was what happened to me. So what happens when someone comes to you with like an anecdote that seems to be really positive and something that's working for them?
Yeah. I think, again, in that trusting relationship, I try and work with people as much as possible. So I completely respect that they've done their research and that low carb could be the way to go. Now, especially working with children, I can work with low carb as long as they are seeing a dietitian.
Mm-hmm.
I won't work with no carb.
Mm-hmm.
So I think low carb, as long as they are nutritionally sound as assessed by a pediatric dietitian, then we can work with that. But people, and you would have found this yourself, did you get off insulin altogether?
No.
And this is people's biggest aim, is we can get off insulin, and they have to understand that with type 1 diabetes, that is not going to happen.
Right, and that is just a pursuit that is so misleading, because why would you want to get off the life-saving hormone? Like, if your pancreas...
they think it's evil. So they see it as a medication, they see it as a drug, they don't want to take it, they think it's poison.
I find this incredible, because I think that we should have the complete opposite mindset. We should go, Frederick Banting and colleagues, you are amazing. Thank you so much for creating this life-saving hormone that I can inject.
102 years ago. It's not that long ago.
Right. If you got diagnosed 103 years ago,
you died.
You're dead in what, like a month or two?
Yeah.
Starvation diet. Yep. Quality of life is terrible. Like, look at the quality of life we have thanks to pharmaceutical intervention.
Yeah.
It's so strange that people are anti-insulin.
I think it's not anti-insulin, it's anti-pharmaceuticals, because again, especially since COVID, especially since the narcotic business, there is huge stigma about the pharmaceutical industry and that they're only there to make money. I think the other thing that misleads people is the honeymoon period. So as you will know, when you're diagnosed with diabetes, with type 1, there is still residual insulin production, which sort of kickstarts once you give that first insulin dose. And people's insulin requirements can drop dramatically during that first 6 months to a year, however long their honeymoon lasts.
This is my story.
Right?
Yep.
And it should be called anything different. I think whoever called it the honeymoon period is just like, it's anything but. But that then leads people to do some more research and come back and see me and go, I told you, we're off insulin.
Yep.
And it's getting them to understand that physiological process that's happening and that it will come back again.
That's exactly what happened to me. My insulin requirements dropped by 70 to 80%. I watched this downward trend, and I'm thinking, hey, if I just do this for like 2 more months, I'll be on zero. I'm good. I've cured. Yeah. And it's so false. And then you have the flip side where you think you're on this, great path towards not needing any insulin and curing, so to speak, of diabetes. Yeah. But then the honeymoon phase ends, your pancreas is on zero production, and then all of a sudden your blood glucose starts to go up, your insulin requirements go up. Yeah. And then you feel even more out of control and lost. It's just this storm where you're trying to find yourself. And I think it is probably an important part of the education early on is to explain to people, okay, here's what to expect.
Yeah, absolutely.
This is the honeymoon phase. We hate the name, but this is what it means.
I'm going to rename it.
Yeah, seriously, it does.
Yeah.
There are a few things in the diabetes world that I wish we had different language and names for. I got in trouble, I'm not going to say it now, but I got in trouble for wanting to, have a better way to describe the difference between type 1 and type 2, because that doesn't tell you anything about the pathogenesis, how it manifests. 1 and 2. People forget which one's which.
Or they say which one's worse.
Right. Yes, that was one of the other things people say to me.
Yeah.
So when I say I've got
the good
or the bad type, no, that's the good one. I'm like, I don't know, what's the bad one?
Yep.
This one sucks. You know what I mean? Like, they both suck. Diabetes is hard.
Yeah.
I actually had a statistic that I wanted to talk to you about. Okay. 66 to 73% of people living with type 1 diabetes do not have their A1C at target. Ooh. Right? It's a very, very large percentage.
Yeah.
Okay. I got this from this to be honest. I can't remember the exact source, but it was from a slide at the ADATS or whatever that conference was, the ADC, was it, in Perth? A big Australasian diabetes congress, one of the biggest in the world. And I got this from a slide of one of the researchers. And it made me think, sometimes because I'm so close to my own diabetes and I see great numbers and my A1C is very good and my time in range is great, that we set a standard that is just so unrealistic and so, maybe it even fuels some of the shame and guilt around kids who are struggling. And diabetes has so many layers to it. It's all about self-management. Mm-hmm. No one's doing it for you. Your parents, of course, help you when you're a kid. You've got your educator, you've got your doctor. But then there's the psychological part of it. Then there's the internal motivation. Then there's the judgment and pressure. Then there's the social side and the physical and the mental. There's so many things that lead towards this statistic being 66 to 73% of people do not have their A1C at target. When a kid and their parents comes to see you, how do you tell, what is the target? What is like a good time in range target and an A1C target for a young kid?
Oh, I hate these numbers.
It's hard, right?
So look, if somebody is on one of the automated insulin pumps, like you say, the aim is to have them below 7%, below 7.5%, with minimal hypos, with a time in range of 75% or more with less than 3% hypos.
Okay.
It's a lot of work.
It's a lot of work. Okay, but let's just explain to people why these numbers exist. I know you said you hate these numbers, and I do too. There's a part of me that hates them, part of me that says we need to listen to what the research is saying.
Sure.
The evidence seems to suggest that if you can achieve a sort of threshold, let's call it, of control, where your A1C is 7% or below, your time in range is XYZ, that your risk of developing complications goes down.
Exactly.
Right. So how do you say that to a kid who doesn't care? They just want to go back to school, eat lunch with their friends, play in the playground. How do you get that message across to a young kid?
Drew, if I knew the answer to that, I would retire happily.
I know.
It's one of the hardest things. And I often, especially during those adolescent years, like you said, they don't care. They do not care about long-term complications. When they reach adolescence, you have different carrots to dangle. You can talk about driving and how if they're not achieving a safe time in range that potentially we might be able to stop them driving. You can talk about things like sexual performance, which will really bother a teenage boy, as you can imagine. But until they get to that stage, telling a young child that time in range or not bolusing for their carbs or over-treating their hypos so that they're always running high, it means nothing. Telling the parents, again, sometimes it means nothing, sometimes it doesn't. You've just got to ride out those years as best you can. And as I said, if we can I'll get most of the majority of kids will fortunately decide that, pumps are the way forward. You can realistically achieve a very decent level of control early on and help reduce those risks. But I genuinely don't know the answer to your question of how to get that message across.
Yeah, there's no easy answer to it. And I feel like there's the added, so as you say, like you could say to a parent or the child themselves, these are the things that could happen to you later on, but they're just living in the moment. They're not planning their future. They don't actually care about that. So how do you tap into the internal motivation? Because that for me is like when I'm, I consider myself, say, a coach or a trainer or, somebody who's working with young athletes or kids or whoever it is. I'm usually looking for how can I get inside of them to get to that internal drive. Because I think that with the internal drive, if it's strong enough, you're good. You're going to be good. Like that is going to keep you on the path. Yeah.
And look, if you've got the right sort of personality, you can tap into that with the child and turning it into a bit of a competition. We can come back next time and exactly. The problem, I think, that both parents and young children especially, the reason they will have a higher time in range than is ideal is because of that fear of hypoglycemia. They're terrified. And you said yourself before we started, I said, where do you feel worse? And you said lows, without doubt. A lot of people will cruise along running high for years at a time and they don't feel it, whereas they feel their lows significantly. So that's the fear factor. So again, we're really lucky with technology now in that it's cutting a lot of that out, that you can start reversing the fear. It's always going to be there. But when people trust the technology and knowing that likelihood is significantly less, you can persuade them, hopefully, with more emerging science coming along of that, keeping in tight control and what that's going to do for your future. But it's hard.
I know. I mean, let's talk about some of those mental challenges that sort of impede people from achieving the best diabetes management that they could.
Yeah.
Like, let's talk about the link between diabetes and depression and anxiety.
Yeah, huge.
I mean, I don't know the stats off the top of my head. I think I've said them on a podcast previously, but there is a strong correlation.
It's frightening.
And it's bi-directional. So people who are depressed have a likelihood to develop diabetes and vice versa.
Yeah.
When you have diabetes, you're, at an increased risk of developing depression. Yeah. Do you see this in young kids? And is this something you screen for? Like, who does a young kid need to talk to? Is it a psychologist? Is it like, how do kids deal with this?
I think, unfortunately, it's something that we haven't focused enough on until recent years. And again, unfortunately, the resourcing is extremely low. Not many hospital teams will have a psychologist attached to them. Getting out there in the community and finding a psychologist, A, who works with children, but B, understands the impact of a chronic illness, is another factor. Quite often people will go to a psychologist, and the psychologist with the best meaning in the world will recognise burnout or depression in this person and say, well, just give yourself a few days off. Now, you well know in diabetes, unfortunately, you can't do that. So we do need to get better at screening, and there are better screening tools you can do now to try and establish if a parent or a child, a child or a parent, I should have said in a different order, are showing signs of diabetes burnout. What I often say to my young people is, you don't have an option to not do this. It has to be done. But if you're struggling, hand it over to someone for a few days. So I've got adult friends of mine who will say to their partner, can you just take this on for a few days? Can you do my monitoring? Can you listen to my alarms? Can you count my carbs? Whatever that might look like, just so that they can switch off for a bit, because we can't ignore it.
Wow.
So there does need to be more money put into mental health support for people with chronic illnesses, not just diabetes.
So what does burnout look like? What are the signs and symptoms? If someone's listening to this and they're thinking, hey, actually, I think I'm burnt out.
Yeah.
What does it look like?
I think being more overwhelmed than usual by the stuff we were talking about before, in terms of people will see someone with diabetes and just go, well, you do a finger prick or wear a CGM, you do an injection or just press a button on your pump and you're good to go. But they don't see those. I saw a presentation recently where this lady living with type 1 diabetes said she counted something like 42 thought points that she had to consider between getting up in the morning and leaving the house for work that weren't just your normal
Regular,
every day, I've got to brush my teeth, I've got
diabetes
to do this.
Related
they were
thoughts.
diabetes related. 42 of them invaded her mind. And I think it's getting people to understand that you're allowed to have your days where you go, this is more overwhelming than usual. Because I think it's, I don't know, Drew, you tell me, you live with diabetes. Is it always constantly there on your mind?
Well, this is why I asked you the question, because in doing research around anxiety, depression, burnout, mental health, and diabetes, I think I almost self-diagnosed a large degree of anxiety that I didn't even know I had.
Yeah.
Because
that shows huge self-awareness.
I sort of was reading these lists of signs and symptoms, and I realized that only recently certain things have been bothering me that never used to.
Yeah.
And I think it's just like, if you think about it, you're carrying this load for so long. And as you say, diabetes takes no days off. And if you take even one day off,
you're punished for it.
Yeah. So I think I've been carrying this, like, and I'm somewhat of a perfectionist. Obviously, I've had to let go of that thanks to diabetes in many ways.
Yeah.
You learn that you can't be perfect.
Yeah.
Which is great. It takes a bit of a load off. It's a bit relieving. But I still have, like, I want to be like a high achiever, and I want to, do my best. So I think that I've been carrying this for so long, and I've never spoken about it.
Yeah.
That's the other thing I realized. Like, I have not leveraged health professionals around me at all to the extent that I should be.
Yeah.
And even just speaking about it. It was at the ADC in Perth. I was sitting at a table with a bunch of other diabetes educators, and one of the educators who I became really friendly with, they have the Perth Diabetes Centre. It's an amazing place. He basically said to me,
I know who you mean.
You know them?
Yeah.
They're the best.
Amazing.
And he goes, who's your psychologist? And I'm like, what? I don't have one. And he's like, oh, you've never spoken to anyone about your diabetes, mental health? I'm like, never. And I think that that's also sort of was a wake-up call for me. It's like, you need to offload this stuff. You need to talk about it.
Yeah.
So I don't think I have burnout because I've never once woken up and felt sorry for myself or, decided that, today I'm just not going to manage as well as I usually would. Like, I've never had those thoughts.
Yeah.
But I do feel like anxiety is creeping into my life. Maybe I'm just getting older and I've got bigger problems in life outside of diabetes as well. I'm not sure. But that's comes with the package, right?
Yeah.
So when you have diabetes, you're still trying to live a normal life. So you have all the other stresses that come with life.
Yeah.
There's just a lot to sort of deal with.
It is a lot. And before we had technology, you relied on a conversation to try and establish that sort of information. Whereas now with technology, and again, this could be double-edged for some people, we looking at insulin pump downloads, for example, can see when someone's struggling. We can see when they've checked out. That might not be great for them that we're seeing it, but at least it gives you something to frame a conversation and start asking those questions.
Right.
As I said, then the problem becomes if somebody does, break down and say, yeah, I'm really struggling with this, where do we refer them?
Yeah.
There's just not enough out there.
Right. What do you see in the pump sort of data that gives you the hint that these people are not looking after themselves properly?
Look, there's a lot that you see. So people will either just not be bolusing at all. So you'll have a conversation of, explain to me why you're not bolusing or what's your reason behind that. They might not be changing their infusion set frequently enough.
Sorry to interrupt. Let's double click on that for a second.
Yeah.
Because this is something I really wanted to talk to you about.
Yeah.
I know personally at least 2 or 3 people who don't bolus insulin, completely skip their insulin at meals because they want to lose weight. These are both...
I was just about to come to that.
Right.
So, yeah, the sorts of things you look for, I'm really glad you've mentioned eating disorders because I want to talk about it.
Yeah.
So people not bolusing, so establishing what's their reason behind that, and that there is an eating disorders checklist that we all should be doing now, knowing there's such a strong link. Girls with type 1 diabetes are twice as likely to have disordered eating to those without. Now, that's a massive statistic.
Yeah.
So it's something that, again, technology has enabled us to see more. So back before we had technology, you would see people with very high HbA1cs and significant weight loss, and it was pretty obvious that they were not giving their insulin so that they wouldn't gain weight. So I think it's about establishing why aren't you bolusing? Is it because you want to lose weight, or is it just because you can't be bothered? Is it because you forget, or is it because you don't want to pull a pump out and have people go, well, what are you doing? Right. What's that? So there could be a variety of reasons.
Right.
The other thing I do see, and now we'll move on to the eating disorders, is with the technology now, if somebody's on an automated insulin pump, they kind of don't get away with it. So where they would just not give insulin before, if they don't do it now, the pump will jump in and give insulin for them. So what you tend to see instead is them either switching off the algorithm or not wearing continuous glucose monitoring so that the algorithm can't work.
Can't talk to the device.
Absolutely. So it's spotting different behaviours now that weren't as obvious before and then trying to have a conversation around it. Wow. Now, the problem is I've got one young girl at the moment who I'm very much seeing this behaviour. The algorithm is being switched off several times a day. There's no boluses going in. I've tried to address this, and her family are adamant that the pump is faulty and that I'm seeing the wrong information. So again, as you can imagine, it's a really tough conversation to have.
Right, because you're dealing with the parent. You're dealing with so many people.
Who's going, there's nothing wrong with my child.
Do you think
I've said to them,
some denial?
Absolutely. I've actually had to say to them, because I sort of skirted around it for a bit to sort of try and say this is what I'm seeing. And they said, no, the pump must be faulty. The pump's been tested. The pump's not faulty. That I've now had to say, just so you're aware, this is quite a common sign of disordered eating. I don't want to use eating disorders because it's a bit strong. And the dad just shut me down. No, that's absolutely not the case.
I know. It's a very delicate conversation.
It is.
I feel for you to have that.
And again, outside of my expertise completely.
It's so hard. I've had patterns of disordered eating without even knowing it because food and diabetes are so strongly tied. They're literally, of all the factors
That's all we talk about.
Right. It's always, even though there are, let's call it, dozens and dozens of factors that affect blood glucose control and all that, food has to be up there as number one.
Yeah.
You know, exercise, of course, there's stress, there's sleep, all that stuff, you know.
Yeah.
But food, we do it every day, multiple times a day. Where do you think this idea that insulin makes us fat came from? I mean, I know that obviously when you're undiagnosed, like for example, in my case, I lost I want to say, 83 down to 69 kilos when I was diagnosed, right? It's a lot of weight.
Yeah.
Right? 14 kilos of weight. And I wasn't overweight.
Yeah.
It was all muscle. Obviously a bit of body fat as well, but I wasn't like overweight. I didn't have a lot of fat mass. So when you're not producing insulin, obviously you're eating all this food, your body has no way of storing those nutrients in your muscle cells, fat cells. Then you go on insulin, all of a sudden you rebound and get this weight gain.
Yeah.
Do you think that that's the point where people go, oh, so the insulin's making me fat? And then they decide.
Sometimes there is that association. Usually, initially, it's the insulin's made me feel better. But a lot of people, again, depending on the age of diagnosis, so I don't see this in the young children, but certainly probably the age that you were diagnosed or even my mid-teens, you know, yeah, they felt shit. Sorry, I hope I can use that word.
Yeah, swear, go for it.
But they also would look in the mirror and go, God, I look good. And then they're getting this insulin and they gain weight. Now, it's not a myth that insulin makes you gain weight because it's a growth hormone.
It's anabolic. Yeah.
So, right? So too much of it will. And I think the second these people figure out that by limiting insulin, you can actually continue to eat whatever you want and you'll lose weight, is something that we have to be aware to just nip in the bud as soon as you can and get these people the help they need. Because, as you say, I think everybody has a degree of disordered thoughts around food. We all do. Show me someone out there who hasn't been on a diet or, you know, it's all we talk about.
Right. Yeah. The eating part of it is something that, like, I feel like it's almost like a taboo subject that people don't want to talk about, the disordered eating part of diabetes.
Yeah.
Almost every single person that I've spoken to over the years that I've been dealing with, I don't want to call it like clients, patients, whatever you want to call them, there's been some kind of thought that I've gone, ooh, I don't know if that's healthy and sustainable long term. Like that thought pattern right there.
Yeah.
We want to get on top of that early on.
Yeah. And even down to back in the early days when people were on twice daily injections of insulin, and because they were on certain insulins, you had to eat at certain times.
Right.
And I think a lot of that has driven this, in that parents would be calling me saying, I'm having to give them 30 grams of carbs and they don't want it just because the insulin's working and the type of insulin we're giving, that's what happens. And I think the association, how many of the non-diabetes population count carbs? Most people wouldn't have a clue.
Wouldn't know what it is.
But because we equate certain amounts of carbs to certain amounts of insulin, it doesn't take long to work out, well, the more carbs I have, the more I need insulin, and then, oh my goodness.
Yeah.
So we'll just cut it all out.
Right, and that's also an easy way to demonize carbohydrates.
Right.
Right.
Yeah, they're bad.
Carbs are causing all of this fat gain. It's carbs and insulin, and you sort of group those two together as the problem.
Yeah.
I've been trying to teach people about like sustainable weight loss when they're living with diabetes. And to be honest, without making it too simple, the laws of calories in, calories out apply.
I know.
Like you just, you don't have to be skipping insulin. You don't have to be people underdose as well.
It's simple maths though, isn't it?
It really honestly is. It's energy in, energy out, whether you have diabetes or not. Yep. Maybe there's some slight physiological differences between people without diabetes and people living with diabetes.
Of course,
but at the end of the day, if
remains.
if you want to have a long, healthy life with diabetes, at a healthy body weight, gain muscle, you can still do it.
Yeah.
And you don't have to fear and demonize insulin. You know,
but also fear and demonize carbs, right? Because I think that the media again is really not good, and especially with all these carb-free diets, ketogenic, you know, all of these types of fads, people without better knowledge just assume that all carbohydrates are bad. And parents of young children don't understand that carbs are the fuel that they need to grow. You know? So it's getting that message across with all that outside noise contradicting everything you're saying.
And there's been a wave of low carb, keto, carnivore now where it's so popular and it's such an appealing diet to especially like young men. When they go, oh, so you're telling me I can just eat meat only and be like the Liver King or whoever these influencers are online and be jacked and muscular and also manage my diabetes and not take insulin, sign me up. You know,
you've got famous people promoting it.
Right.
So
exactly. And these people, they don't know sort of where to find their information. So it's tricky out there. Well, I want to talk to you a little bit about some of these, without going into too much detail about the numbers, but like when people are looking at time in range as a target, that is sort of like, it's kind of like the new gold standard. Can we say that yet?
Yeah, absolutely.
Okay.
Yeah, it is.
It is. Okay. So it used to be your A1C, which was this average essentially 3 monthly blood glucose level that sort of tells you how much glucose was sort of attaching to hemoglobin. Is that a good way to put it?
Yep.
We then realized that, well, the system's doing this up and down all day. We're getting a snapshot. It's not telling us about day-to-day management.
Yep.
Time in range as a percentage is better.
Yep.
And time in range for people living with type 1 diabetes is usually set at 3.9 to 10. Is that
Yes,
right?
that's right.
But some people decide that they want to go for time in what we call tight range.
This is the new buzzword.
This is the new buzzword.
Yeah.
Right. So I think that people living with diabetes, especially their parents, they think, well, you know, my son or daughter has diabetes now. Why can't we have completely normal blood glucose control, just like somebody living without diabetes? Why should we even accept that our control could be any worse than anyone else's? Let's aim for perfection.
Yep.
Right. And then this time in tight range comes about, which is 3.9 to 7.8.
Yeah.
I don't know what that is in milligrams per deciliter for those Americans and other people listening, but
Times by 18.
times by 18, right? So roughly times by 18. But this time in tight range essentially mimics people living without diabetes, how their blood glucose would be over the course of a day, which actually isn't exactly true. Some people go above 7.8.
I'm one of them.
Right. and that's not a pathology.
Yeah.
And that doesn't mean that you're going to have these terrible health outcomes. That is what the human body can do.
Yeah.
So what do you think about time in tight range? You don't have to answer this. It's just...
No, I will, because I recently went to the ATTD meeting in Singapore, and because there's really only one automated insulin device available in most of Asia, which is the Medtronic 780 system, all of the studies that were presented were using the 780 system, and all of them looked at, they're all now talking about time in tight range, producing better long-term health outcomes. So there is a strong push for people to use the lowest possible target of 5.5, the active insulin time of 2 hours, and be aiming for most of the time to be in this time in tight range. Now, I went into these talks going, but I don't run any of my kids really, some of them on 5.5, most of them I run on 6.1.
Yeah.
And the pediatric people I spoke to afterwards, I said to them, you're producing evidence showing minimal hypoglycemia using these recommended settings. And I'm just not seeing that. I see hypoglycemia when I use them, so that's why I go to the higher one. What they said is, and it was overwhelmingly repetitive, every day somebody different from a different country doing a different presentation, showing the same information, no matter what the age group. And I thought, I actually have to, all part of our jobs is being evidence-based, right? And they said, you've got to stick with it. That hypoglycemia will dissipate, will it? I don't know. I have to trust the evidence in going, now we know that this is what's giving our patients the best long-term outcomes. Now, the other side of me is going, do we need to be striving for this level of perfection when we know that mental health issues and burnout are such a problem? And I think this is certainly not my medical advice. This is my personal advice, would be to pick your eligible people. So I've got families out there, and inevitably it's usually the ones that have someone medical in the family, or an engineer or an accountant, right? Those people who are really into numbers will be quite open to trying running that level of tight control. My worry is the sustainability of that and what that does to the child. But I know that the evidence is supportive of it, so I feel really conflicted. Yeah. I haven't answered your question.
No, it's a conversation because I don't think there is an answer.
It's really hard.
It's so hard. As we said, it's this delicate dance. We've already spoken about
You've got to weigh up the benefit worse, and we haven't
cost-benefit
looked
ratio.
Exactly.
What is the cost mentally, psychologically?
And we haven't looked at that enough.
Right.
And I'm so pleased people are starting to now, because it is so significant.
Right. So we know that there are obviously benefits, because as soon as you get diagnosed with diabetes, your risk of comorbidities goes up. Okay, so we know that not having diabetes is better.
Yeah.
Therefore, if we aim for a tight range, or at least close to someone without diabetes, our health outcomes are going to be better. Right. But that doesn't tell you anything about the day-to-day person living with it.
Yeah.
The mental health issues, the impact on their family, maybe their work as they get older. Like as a kid, sure, functioning at school is important, but as you go into the workforce and then you have a family, there are so many other things you're trying to think about. So until these systems can do it for you and achieve tight range for you, the person is doing the work.
Yeah.
It's very hard. I looked up some of the stats around this. So going back to what we said about this target of 70% time in range, tell me if this has changed.
75% plus what they want.
Okay, so 75% plus. 75% time in range or 45% time in tight range will revert cardiovascular disease risk to that of a non-diabetic state, right? So that sounds great. Mm-hmm. It makes you think, well, yeah, I want tight range because I want to revert these associated risks.
But you're going to drive yourself into the ground achieving
What's it going to take, right? So this is the thing. Like, what is that going to take? And what if I'm not on an automated insulin delivery system and I'm on MDI with a CGM and I decide, you know what, I want tight range. How many injections am I giving per day?
Yeah.
I might be giving 20 injections and micro-dosing insulin all day long.
Yeah.
It's just exhausting to think about. And then another statistic that I found, which I hope is accurate, again, this was from one of the conferences, a 10% increase in time in range can equate to a 17% reduction in microvascular complications and a 25% reduction in CVA, which I think is cerebrovascular something.
Strokes,
yeah, right? So this to me is a very empowering statistic.
Yeah.
Right? 10% increased time in range. Very achievable. A lot of people can do it. It's not saying go from 35% time in range to 75. It's saying just increase it by 10%.
Yeah.
And look at the benefits that you're going to get. How do you sort of tell people that when you're sitting face to face with them to make these sort of like micro steps or these small adjustments instead of aiming for perfection?
So again, in terms of cardiovascular risk and stroke risk, all of that sort of stuff really isn't going to impact on a child.
Right.
The other one I heard when automated systems were first coming out, which actually really resonated with me, I don't know how you'll feel, for every extra 8% increase of time in range equates to a month of the year.
Oh, wow.
And I liked that one because I thought that for me was much less scientific, but quite impactful to go, imagine if you could achieve an extra month per year of sugars being in range by an 8% increase, which isn't that much.
Yeah. That's really good.
Yeah.
It's very digestible. It doesn't seem overwhelming. And I think maybe for parents as well, because a lot of parents, I know one in particular that I can think of that I've worked with, the standards of care for their kids are so high that, I mean, I just feel sorry for these kids.
Yeah.
I really do. I feel like these kids are not only trying to manage their diabetes, not only trying to do the best for themselves, but then they got the pressure of their parents who are essentially micromanaging and have access to all of their data. So the mother or father could have their phone watching their kid playing outside. They can see their blood glucose, they can see their insulin.
They're texting them 16 times a day.
Do you see that?
All the time.
So what, just parents getting a bit too involved? Well,
and look, you get why they are, right? With this technology is brilliant, but it's got those curses of exactly that it has. And I have a very open conversation with people about it that I say, we're going to have to put some rules in place here because the child, and usually the kids are a lot savvier at faking the technology. So they'll make sure mum and dad can't follow them anymore. They'll unfriend them on the apps, but they'll claim that they haven't, and the parents don't actually have the savvy to know how to check that. They're just assuming that the apps are faulty, right? So when eventually people will admit that to me, and I had this conversation with a couple the other day, a mum and a son, that I said, and I always say, it's part of my very poor mental health screening would be to say, what's the worst thing about having diabetes? Or what do you and mum or dad fall out about most? And it's usually down to things like the constant nagging. The question around what the number is tends to have disappeared now. That used to be a huge one that the kids would say, you know, my brother gets asked if he slept well, I get asked what my number is.
Yep.
That's gone now that we've got the visibility, but instead it's the why haven't you done, or why did this happen and why didn't you do that? And it's more they're seeing the information and then they're questioning them on it. So I said to the parent, the reason they're cutting you off is because they can't hear this conversation anymore. It's getting them down. It's annoying them. And I said to the kid, the reason they're asking is they're worried. So we just put rules in place that if the kid allows the parent to see and texts the parent when they haven't done something to go, I'm aware my sugar's low, I'm aware my sugar's high, I've fixed it, whatever, then the parent's not allowed to intervene. And we just try and work out things like that. But again, it's just not going to work for everyone because, you know, parents will say to me, well, you don't know what it's like. And I go, no, I don't. No. But this isn't working.
It's not working.
So...
Yeah, you're like a family psychologist at this point. It's like you're trying to do so many things as a practitioner.
Drew, most of my appointments are not talking about diabetes. It's counselling.
Like I wanted to get into, you know, all of these different management sort of tips and tricks, like sick days, travel,
Yeah.
time zones, when to split dose if you're on MDI,
Yeah.
dawn phenomenon, all these things. But as I talk to you, I think like the biggest issue, which
There's
really
guidelines on that sort of stuff. That's easy to do.
The hardest thing is the psychology and the mental health, and then the
Without
relationships between the person living with the condition
Yeah.
and everyone around them,
Yeah.
and how much diabetes affects both
Yeah.
directions of the relationship.
Yeah.
The parents also feel, as we said before, maybe burnt out and
It
exhausted
destroys
by it.
relationships. And that's the bit, again, that people don't see. Like you said, that the sick day management, the sports stuff, all that stuff is really significant. But there's guidelines on how to deal with that. And it's achievable, but it's the stuff you can't see. It's the stuff that goes on behind those closed doors in families. A lot of the reason I do home visits, you gain an awful lot from the psychology of a family by being in the home and seeing how everybody interacts and what else is going on and how busy they are and why diabetes might be taking a back seat.
Yeah, I guess you've got to see it not just in your clinic in those four walls,
Yep.
but see it where they're spending their most time.
Yep.
It's going to expose a lot of the fundamental sort of issues that
And
are
it
coming
really
up.
does.
I'm sure you see some sort of wild stuff. Wow. So yeah, there's so much that I wanted to talk about around those management things, but I think let's push that aside.
Yeah.
Let's focus in a little bit more around what are like the sort of levers that you think people can pull on that will allow them to live their best lives as both the person living with it as a child and their parents. So like if we think about the lifestyle, because this condition is so focused on numbers that we get lost in the numbers and we forget to live our life sometimes.
Yeah.
What do you see as a healthy lifestyle for someone living with diabetes as a kid, right? Like how does a kid maintain good mental health, good physical health? I know it's tough, but just let's go basic guidelines. Whilst living with diabetes, like what are the sort of things that you would expect people to be doing each day, lifestyle wise?
I think obviously they have to talk about it. They have to talk about it as a family, but it's getting that balance of having an open conversation about diabetes so that the child does feel able to say when they're struggling and they don't want to do it, or that their parent's annoying them, or they're worried about something. The parent needs to be able to get that balance of course they're worrying constantly about their child. They're sending them off to school where they're going to be in somebody else's care. But it's trying to normalize that diabetes cannot be the be-all and end-all. I have many families say to me, usually either soon after diagnosis or soon after moving to a pump, for example, they were going to have a sleepover, but we're not going to do it. We were going to go on a family holiday to Fiji, but we've decided to cancel. So it's having that conversation early on to say, don't let diabetes define you. Don't let diabetes control you. Try and make it the other way around. And don't let it stop you doing anything you want to do within reason. So it's just letting people know that I don't believe in not doing anything because of diabetes. I believe in planning it properly. So unfortunately, again, like I said, you can't switch off to it. It's there, but we need to shift that focus on, well, we're going to make it work around what we want to do today. And we are going to go on that sleepover and it's going to be all right.
Without putting it out of sight, out of mind.
Exactly. And it's getting that to go, it's still there.
Right.
Mum's still going to need to be able to follow. Interestingly, recently I've had quite a few kids go off to the UK on gap years. Their parents' biggest concern is their child's on the other side of the world.
Right.
So again, it's having the conversations of what's appropriate, what's not. Because I had one mum say, well, she's just not going. I said, you can't stop her. She will resent you for the rest of her life. And I said, diabetes cannot dictate what she wants to do with her life. So we put things in place.
Right.
And those things in place were, you get linked in with a local hospital before you go. Parents are always to be able to follow you. If they can't, there is somebody that they contact at the school to come and get you. And, that sort of stuff. Make sure a friend knows. Safe alcohol consumption. We're talking about all that sort of stuff as well. It's all going to be there. We've just got to learn how to do it properly so that diabetes is there, but it's not there.
Yeah.
It's a hard one.
It is hard. No, but I like the way you say that because we know it's always going to be there, but it doesn't have to be in your face all the time.
Yeah, it's been there for long enough.
Right. Find a bit of a way to have some distance and feel like, sometimes I think there are things that I do in life where I completely forget I have diabetes.
I love that.
Right. And I'm trying to chase those moments as often as possible.
Yeah.
Right. So that's what the sort of advice that I give to young kids. It's like, think to a time, and it can't be like a week. I'm talking like they're momentary little fleeting moments where you just have completely forgotten that you even have it. And it usually for me comes in the form of playing sport, exercise, some kind of like physical pursuit, although there are a lot of diabetes related thoughts attached. But when I'm in the moment, you know, for example, when I'm diving into the ocean or I'm surfing a wave, I'm not thinking about my blood glucose. When I get off the wave and I'm sitting out there, sure, I'm thinking about it, but I've got a glucose gel in my wetsuit or my pocket or whatever it is. But I think to just take the load off for kids and parents, it's like, you've got to do those things, find those things in your life where you just forget about it.
Yeah.
You know, you're still going to be safe. You still make sure that you've got plan A, plan B, but just look for those kinds of things.
And balance your fear.
Right.
It's the balance word again. It comes into everything, but it's you've got to a degree have a healthy level of fear, but don't let it control you.
Well, let's talk about fear, because I often say that fear is not a very good long-term motivator, but a very good short-term motivator, right? So like when I was diagnosed, there was the fear of all the complications, blindness, limbs being chopped off, all that stuff, which made me want to immediately like manage my diabetes well. You're not thinking about that 6 months, a year later, 2 years, 5 years in. You're not thinking about that often. Like, the thought will come up every now and then, but it's not like I don't get out of bed and go to the gym because I'm thinking about going blind in 40 years. You know what I mean? Like you're living for joy and joyful moments, because that's the best motivator for like real change, right? So like finding joy in things. What do you think are the things that people fear in diabetes that are maybe, you know, they're important to understand, you know, the short-term fears and long-term fears? What are the main things that come up for people? What are they scared of? Hypos, going low.
Hypos is the big one. And I mean, you will understand that completely because you just feel awful. People reading horror stories about things that have happened to other people and worried that that's going to happen to them.
Dead in bed syndrome, those kinds of things.
Yep, those types of things. Will that happen to me? And I think a lot of fear comes from parents, and I totally understand why. That, again, back to the sleepovers, back to sending them off to school, it's trusting somebody else to do as well as you've done with your child, right? And there's that fear that then the children... I go back to many years ago, I was doing a diabetes camp and I got up in the middle of the night and one of my well-known patients was pacing up and down at 3 a.m. and I said, buddy, what are you doing? And he said, well, mum's sleeping, so I can't sleep until she sleeps. I can't sleep until she wakes up because she needs to watch me. So again, this mum had... her fear had made her child believe that something horrendous was going to happen to him while he slept unless she was awake to watch him. So they work shifts. So it's very hard to dispel that level of fear when it takes over somebody's every living thought. And again, fortunately, we've got great technology now which can take away a lot of that and build more confidence. But the fear of everything, fear of drinking, fear of living a normal life. Many parents ask me at diagnosis, will my child be able to have children themselves? Will they have diabetes? Right. That fear, passing it on, you know? Yep.
And then the fear of not managing properly, and then what we just spoke about before, those long-term things that your quality of life towards the end of your life is really diminished due to these complications. But again, like if we just come back to what are the motivators that are going to make you healthy, I don't think fear is a good one.
No, I don't.
I think it's good to know about them, but find the joy. And for me, it's the joy of the things that make you happy every day.
Yeah.
Because then you're going to wake up and do those things.
Yeah. What can you do?
What can you do, right? And they'll feel like they require less effort.
Yeah.
So people ask me, like, how do you stay so motivated to go to the gym every day? I love it. I don't think it feels like I need any motivation. Yeah. Like it's so easy.
Yeah.
Motivation for me is required to do things you don't want to do.
Yeah.
How do you find that motivation? Like I'm just internally motivated because I love the feeling of it. And I hope that kids out there can find those things. Like, for example, sport. Like, there's risks associated, but what do you think about like young kids who love playing sport? Is it on the net a good thing or a bad thing, even if the parents are scared of the lows?
Yeah, look, it's a great thing. And I think living in the world we do with social media and with people that, like yourselves, that these kids can look up to. So, you know, you've got your famous sports people, you've got people like yourself that young kids can look up or meet and get the opportunity to go, well, they can do it, so can I. And I think that's huge to help them see that not only are you going to be a normal functioning human being, you can actually function at a really elite level of a sport that you really, really love, despite diabetes. So I think it's getting them to, it's figuring out what makes them tick and then guiding them towards something that will work. And that could be, you know, meeting someone like yourself. It could be going to a diabetes camp and meeting other kids like them because they might not ever have seen anybody else with diabetes. It's finding the motivation, which is hard.
It is hard.
Because some of them don't have any.
Right. And you can't teach motivation. You've got to essentially like guide people to tap into their own source, which is somewhere in there.
Yeah.
But we're not psychologists and it's very hard to do.
It is.
And you've got to really be an expert in that.
Yeah.
It makes me think about Tyson, who obviously was still is one of your clients? Yeah. So he was on the show a few episodes ago now. I'm not sure when this will come out. But it makes me think about a kid like Tyson who has so much internal drive and motivation that I didn't have to do anything, it felt like. I just had to like present myself as a role model or at least a positive example of living a good life with diabetes.
Which is exactly what you did for him.
But then he did the rest.
Yeah.
You know what I mean? So like...
But your presence and seeing what you had achieved was that little switch. Not that he was an unmotivated kid anyway, he wasn't, like you say, but that switched him into going, right, I'm going to do this.
But my point is I've also had clients who have not had that same response. And I just think we're all different. Like I've worked with kids who I thought, you know, I had this great, Tyson was like my first client, you know, I had this great experience with him transforming into like an amazing athlete and just a great person.
You thought, I'm good at this.
I'm like, this is so easy. I'll just pick up the next client, do the same thing. We'll go to the park, we'll work out together. And that's not what happened.
Yeah.
Because the next person didn't have that same internal drive. And I was thinking as you know, as a coach or a role model, how do I get that person to, you know, find that drive inside them? And I couldn't figure it out.
You've got to talk to them, find out what makes them tick. And there's some kids I've been seeing for years that I still can't find that tick in them. I can't. So it's,
And I think that it's an important moment to almost, for myself, to look at the position that I'm in and what I've achieved for my own diabetes health and realize that not everyone's going to be like this. And I don't want to set a standard that's way too high and unachievable for most. Like, it's freaking hard.
Yeah.
It's a full-time job. No one signed up for it. So we need to be gentle in these conversations and how we talk to people, especially kids. Like, I was 22 years old.
Yeah.
You know, I can only imagine how hard it is for, you know, a mother who has a young baby.
Yeah.
You know, what was the youngest? 7 days old, you said?
Yeah.
Imagine, like, it's hard enough trying to raise a healthy child, let alone one with diabetes from
And by the way, you've got to stick needles in it.
Right. Right. While they're sleeping and you've got to do this. Yeah. It's crazy. Well, we have covered a lot of terrain.
We have.
But now it's time for my favorite part of the show, the Dear Diabetes segment, where I usually tell my guests to write a letter to their diabetes, but you're not living with diabetes. So this is going to be the first time that somebody without diabetes, but obviously is very, very, very close to the condition for so many years, can express how they feel about it. And I'm really, really excited to hear what you have to say. So before you do your letter, is there anywhere that I can point people to find you if they want to get in touch or come see you at the clinic?
Yeah, sure. So you mentioned Jane earlier. So Jane Overland and myself run a business called Total Diabetes Care. We're based in Sydney in various locations, some mobile, and we can be found either via our website, where Jane has appointments on her website, so totaldiabetescare.com.au. We can be found on Instagram at Total Diabetes Care, same on Facebook, Total Diabetes Care.
Amazing. Is there anything else you think we haven't touched on that you think is important?
Loads.
Do we do it all?
Loads.
Oh, yeah, there are things.
There's a second episode for sure.
Okay, well, let's do that then. Let's get.
I think with some of the practical stuff you said, like the sick day management, the exercise stuff, the nutrition side of things, I think would be great to discuss as well. But I'm really happy that our focus led us to talk without me realising it was going to happen about a lot of the mental challenges, because even though I don't think we've solved anything, it's hopefully for your listeners to realise that it's okay to struggle with diabetes and just speak out about it and get some help if you are.
It's such a good point. Sometimes I even feel guilty sharing. Like, I try to share everything.
Yeah.
But a lot of my diabetes is quite, for lack of a better term, like successful in terms of my management. Like, I'm very happy with my management.
Yeah.
And sometimes I'll share like really good time in range as hoping that it's motivational for people, but it actually does the opposite.
It can.
And then I get messages from people saying, how do you do that? My time in range is 30%. How is yours 90? this is so hard. And then I think, well, I feel a bit guilty even sharing. And then I get stuck in this position where I'm like, should I be sharing the good stuff or should I just share the hardships? But I think today we really focused on the hard part of diabetes, and maybe next time we'll focus more on the tips and tricks around those practical day-to-day things and management strategies and protocols and stuff like that. Well, it's your turn to close the show.
Well, again, having focused on, a lot of the doom and gloom, I'm hoping that my letter reflects a bit of that, but with a bit of a turn at the end. So I didn't realise I was the first non-diabetes person to do this, so a bit of pressure. But
no pressure.
Okay, so hopefully I can get through this without crying. Dear diabetes, whilst I don't live with you as such, you are a huge part of my life. I've had the privilege of having you in my life for around about 24 years now. And I call it a privilege because of the people I've met along the way, and with the hope that I've been able to help so many of these people during my career. In my years of working with people with type 1, I've seen some impressive advancements in the management, both in insulin improvement, but particularly in technology. I don't pride myself in embracing tech as such. In fact, amongst my non-medical friends, I'm a bit of a novice and a joke. But in my field of work, I've been forced to get into it, and I've also been excited to challenge myself, and what a challenge it has been. I started my diabetes career breezily asking parents and kids to do 8+ invasive finger pricks per day, on top of the 2 to 6 injections of insulin. I said it casually, not recognising the toil this brings to all. The nighttime alarms, the dragging yourself out of bed and waking your child to force feed them juice from the deepest sleep stupor, the worry in those sequential hours, being afraid to sleep in case the worst should happen. Now we're lucky enough to have sensors that can alert a parent or carer or partner of that all-consuming impending doom. I've always described the person and family living with diabetes like the swan, gliding on the surface effortlessly. The person with diabetes appears normal, unaffected, cruising through life, achieving their everyday goals at school, at home, in life. It's the invisible illness. No one, unless they are touched by this invisible demon, knows the work that goes on behind the scenes, the furious paddling under the surface that produces this well-functioning human. The constant thinking about what the day has in toll, what the weather will be like, what food is involved, what exercise or stress might occur. Are they in a growth spurt where hormones might wreak havoc on well-played plans? This is diabetes. It's always controlled my tribe. But what I want to say to diabetes is the tide is turning. The battle is changing course. Technology is starting to and will continue to win. We, the scientists, have found a chink in your armour, so to speak. We are starting to take control, and this thrills me. No longer is this enemy going to control my tribe. We, the people, have found ways to overcome you, to challenge you, and to show you you're not in charge anymore. This albatross you have hung around many's necks for so long is soon to be reversed. We have technology now, and even more exciting technology coming that will show you who is the real boss here. The real boss is my people, my patients, their parents and extended supporters who are sick of this control. My tribe will be in charge and in control of this thing called type 1 diabetes, not the other way around. And I can't wait to help facilitate this victory. It's long overdue.
Wow. What a perspective. I feel like you're the leader of the tribe. It's so nice to hear someone with a voice like that. Yeah. And to have so much passion, having not even lived a day with it.
Having read that.
So good. So I've got chills a little bit there as well.
Yeah.
Wow.
But it's something I really believe, Drew. And, I wouldn't have been able to have that conversation many years ago with people because there wasn't this exciting future. And now I really believe that it's changing fast.
Right. It does feel like an exponential change in technology and how we live with it. And I mean, you even see, we didn't speak about this, but like on the streets, you'll see people using diabetes tech who don't even have diabetes.
Yeah.
So like it used to be stigmatized to like have a pump or a device or this. Now everyone's wearing CGMs, which is something we haven't spoken about, but I've got my own opinions on that. I've spoken about it a lot before. But the times have changed and you can really, really feel it. I love that analogy of the swan.
Yeah, it is though, isn't it? It's what we were saying before.
And I guess that's an even better sort of metaphor for how I sometimes feel that guilt where I put across this image on social media that it's diabetes is easy, look at me, I'm doing great, you can thrive, blah, blah, blah. But under the surface, furiously paddling away, and I think I need to, honestly, like even just having heard you say that, I think I need to do a better job of showing the fucking dark side of it, and like being honest about those days. I have done it, in the past, but not enough.
Yeah.
I really think I need to do a bit more of that. So watch this space. My social media is about to change. It's going to be all doom and gloom now. Well, thank you so much. What a great conversation. I can't wait for round 2. We'll dig into all of those other topics. And
Awesome.
what a great letter.
Drew.
Thanks for being here.
Thank you.
There you have it. I hope that conversation allowed you and your loved ones to be seen and heard. Diabetes is hard, but you're not alone. As always, I'll see you in the next episode for another dose of inspiration and education.